In today's clinic, we will learn how to examine the larynx. So we can divide this examination of the larynx into two parts. External examination, in which we will try to see the different cartilage and structures related with the larynx, and second is the indirect laryngoscopy examination. So first we will perform the outer examination, external examination. So now first I will show you how to examine the larynx externally. So for that we will be doing the neck examination. So we have the patient to extend the neck so that we can see all the structures. So uppermost structure that is very quite distinctly we can see is this thyroid bone, and below that you can see this thyroid cartilage, Adam's apple, and two lamina of the thyroid cartilage, and in between this you can see this thyroid membrane will be there, and this little part from the little part of the piriform fossa. Then we can see very clearly this cricoid cartilage. So cricoid cartilage is the limit, and just below the cricoid cartilage will begin the trachea. So this lower border of the cricoid cartilage lies at the level of lower border of the sixth cervical vertebra. So we can see this cricoid cartilage and this thyroid cartilage and heart bone. In cases of CA piriform fossa, we can see some swelling here in the region of the little part of the thyroid membrane, and even the little part of the thyroid lamina. Then this is the most common site for this subhyoid bursitis swelling. Also we can see here sometimes, and another common swelling that is in the thyroglossal cyst, that also that we can see here. In cases of cancer of the anterior commissure, we can see this widening of the thyroid lamina. And then we ask the patient to take deep breathing, and during that also normally the throat should all these structure they should move. Unda saas lo more khulne. And then we ask the patient to swallow saliva, and then you can see that all these structure they will move. Tu kari jao. So all these structure we can see that they are moving. And in cases of thyroglossal cyst, even that thyroglossal cyst, if you ask the patient to protrude out the tongue, even that will move. Jibar kado. So you can see something that is moving. Andar le jao. Pari jibar kado. So you can see some movement of this. So that is normal. But in cases of carcinoma, there occur adhesions, and advanced lesions, they will not allow this part of the larynx to move along with the swallowing or along with the deep breathing. So there occur fixity of all these structures in advanced stages of cancer of the larynx and laryngopharynx. Thank you. See how to perform the indirect laryngoscopy examination. Actually, this indirect laryngoscopy examination, in this process, we will be seeing not only the larynx, but we will be examining the laryngopharynx and some part of the oropharynx. So the patients who have chronic problem of the throat, like this hoarseness of voice, or difficulty in swallowing, dysphagia, or any neck node, or any chronic sort of irritation, foreign body sensation, any little pain in the throat. So in all these conditions, we should perform the indirect laryngoscopy examination. So we can perform this indirect laryngoscopy examination in two ways: with the help of laryngeal mirror, that is the outdoor procedure, and then with the help of endoscopes also, flexible as well as rigid laryngoscope, we can examine the larynx. But right now I will try to show you the process of indirect laryngoscopy examination. For this you will need the laryngeal mirror. This is the laryngeal mirror, and then this is the right posterior laryngoscopy mirror. So you should know the difference between the laryngeal mirror and the posterior laryngoscopy mirror. Laryngeal mirror shaft is straight, whereas the shaft of the right posterior laryngoscopy mirror is bayonet shaped. So that is the main difference. And if you see the size also usually the posterior laryngoscopy mirror, they are of smaller size than the size of the indirect laryngoscopy mirror, laryngeal mirror. So first we will ask the patient. I will need headlight. Let us start the examination, this indirect laryngoscopy examination. So for this definitely I will need the headlight. I will need a gauze, piece of this gauze, because it will hold the tongue. And before putting the laryngeal mirror, we should do something for the fogging. So either we can put just few drops of the saffron, so that will prevent the fogging, or we can little warm up the mirror with the help of spirit lamp. You have the patient, and the patient position is very important. Patient should be in a very straight and relaxed position. Yes, and the head should come a little forward. And then we have the patient to protrude out the tongue. During indirect laryngoscopy examination, we will be examining the structure, not only the structure of larynx, but we will be seeing some structure of the laryngopharynx as well as oropharynx. So mentally we should repeat all those structures so that we do not miss anything. Otherwise, usually what happens, we directly jump to the vocal cords. So it's not only the vocal cords that are examined, but other parts also they need examination. So we should start from the upper and then gradually we go to the lower side. So the most upper side is the base of the tongue, that is also called the posterior of the tongue, we can see. Then vallicula we can see, there are two valliculae on either side. They are separated from each other by this median glossoepiglottic fold. Then we can see the laryngeal surface of the epiglottis, lingual surface of the epiglottis we can see. Then we can see the pharyngoepiglottic fold. So this pharyngoepiglottic fold, they will separate piriform fossa from the vallicula. Then gradually if we go further down, then we can see the airy epiglottic fold. We can see the arytenoids, and laterally we can see the piriform fossae. So the medial boundary of the piriform fossa is the epiglottic fold, and the lateral boundary of the piriform fossa is this allows the thyroid cartilage and thyroid membrane. And then we can see the false vocal cord we can see. Sometimes we can see some part of the ventricle also that lies between the vocal cord and the false vocal cord. Then we can see the vocal cords themselves. We should try to see the movements of the vocal cord, because in cases of paralysis, one cord may not move. So that can lead to vocal cord palsy. And then we should see for in all these structures, we should look for any ulcer, should look for any growth, and particularly in the laryngopharynx and piriform fossa, we should see for this pooling of saliva. So the pooling of saliva is there, we can see in the piriform fossa, that indicates that there is some obstruction lower down. And the most common cause of this obstruction is usually the malignant growth. And in cases of foreign body cricopharynx also, we can see the pooling of these secretions. So mentally we should repeat all those structures so that we do not miss anything. Thank you. Protrude out the tongue. Then we'll have to hold the tongue like this, and with the index finger we can retract the upper lip, and then we introduce the laryngeal mirror. You can see the base of the tongue, vallicula, epiglottis, pharyngoepiglottic fold, piriform fossa, postcocoid region, airy epiglottic fold, arytenoids, and take a mixture. You can see the movements of the vocal cords. They are normal.